Today we're going to talk about brow lifting and the evolution of brow lifting and why we do brow lifting as a cosmetic procedure in conjunction usually with eyelid surgery. And things have evolved over time, and I started out in 1983 doing coronal brow lifts, which was more or less the standard of the time, and then follow that by doing endoscopic brow lifts starting around 1990. Today we have a special guest, and I'm very, very excited that Dr. Gerald Daniel from Louisville, Tennessee. Is that right?
Kentucky.
Uh, Kentucky, excuse me. Stupid me. Kentucky is with us today, and he is a world authority on brow lifting, and I'm extremely excited about this conversation. He's a world authority not only on brow lifting but on many other aspects of plastic surgery. He's widely published, and he co-authored a very important paper that was published in the plastic surgery journals on what's called gliding brow lifts. So, Dr. O'Daniel, I would like to hear your thoughts about, number one, why we do brow lifting in conjunction with eyelid surgery and or usually with eyelid surgery, and why it's necessary, and I'd like to hear more about what you have to say.
Well, thank you very much, Joel, for that kind invitation and to be here today, and thank you for those kind words for the introduction. You and I are same generation, and so similarly, I was raised to do brow lifts with the incision that goes from ear to ear, called a coronal brow lift, when I was very young. And I was ENT facial plastics, just like you. Did facial plastics fellowship with Mark May back in the day, and then did a full plastic surgery residency, and then did a craniofacial pediatric fellowship. So the coronal incision, where you make the incision from ear to ear, was the workhorse of most of my surgeries for 20 years. However, and being a young surgeon, it was just incredibly fun to do such a big operation. However, it wasn't quite as much fun for the patient, if you recall.
Yeah.
And we had all kinds of problems, from scar tissue to depressions, and they were numb for the rest of their lives, and we pulled their foreheads up high, and they had too much forehead. And, for you and I, our foreheads are getting too long anyway.
Mine for sure, but I've always had a high forehead. Okay.
And, but our aesthetic goals in the 1980s were a lot different. We were talking about how high can we raise the eyebrow, and we would say, well, if we take 2 centimeters of scalp out, we can get 1 centimeter of elevation, and we had no really objective data to say, what are we trying to achieve subjectively? I mean, we're trying to create a beautiful brow eyelid junction, but back then our metric was how high can we get the brow. And so you see the starlets walking around with their eyes pulled like this. So,
Right.
then
the deer in the headlights.
The deer in the headlights, and some people liked it. And you actually still see quite a bit of it walking around the streets.
Yeah.
They're older, but not as often. So it was in the 90s when Feldman Eves and Fuad Nahai first published the concept of using an endoscope to raise the eyebrow, because Feldman Eves came out of general surgery, and they were using an endoscope for everything. You and I were on that wave of using the endoscope for sinus surgery, so we were facile at using a scope. And so the idea of minimizing the incisions became our goal then. And we were still trying to measure how high can we raise the brow. Well, the reality is, as we've evolved aesthetically, we realize we're not trying to raise a brow really high. All one has to do is cruise the Sunday morning New York Times fashion magazine, and you won't see young, beautiful eye and brow relationships with an eyebrow that's pulled really high. So our idea of this how high can we pull the brow, has evolved to how do we shape and create a beautiful brow and a beautiful relationship between the eyebrow and the eyelid. And we want to do this by minimizing the impact of the surgery. So the endoscopic surgery was quite good at minimizing the incisions. We were able to minimize the complications related to hair loss and anesthesia or numbness of the forehead, but we still weren't able to shape and create a beautiful shaped brow. And, we go back 40 years before the coronal brow lift. Casaneris was doing direct brow lifts. And so this transcutaneous incision right above the eyebrow actually was a wonderful operation to creatively shape an eyebrow. So you create a better shape. So from my personal evolution, I was doing a lot of brow lifts in 2000, early 2000, and then there was this invention, I guess I should say FDA approval of something called Botox. And Botox, suddenly we were shaping brows, and by paralyzing the orbicularis muscles, which cause the brow to pull down, we suddenly were getting the brows elevating on their own, and my incidence, my use of brow lifts became much less common. And one of the main reasons they became less common is because the endoscopic approach, which I had adopted in the mid-90s, was unpredictable. Sometimes it was awesome, and sometimes in 6 months I couldn't tell that it worked. And sometimes I would pull it too high and it wouldn't come back down. So this unpredictability really forced me to somewhat abandon brow lifts in the mid-2000s. And I used it when I needed it. So now we're at a point where we're looking for something a little bit different, and our aesthetics for eyelid surgery, eyebrow surgery have changed over time, where we're actually looking at what is a beautiful eye and a beautiful eyebrow. And for me, the evolution started in the mid 2007, 8, 9, 10, when all the studies started to evolve that looked at aging and facial volume. So facial volume was critical. We realized that, I was taught in the 1980s, you can never take enough fat out of an eyelid because it's going to come back. So we were denuding the upper lids and denuding the lower eyelids. And I remember my plastic surgery textbook had about a paragraph on upper eyelid surgery. It's easy. Just throw all the fat away, throw all the skin away, take all the muscle away, and just take enough to where they can't
Yeah.
close their eyes.
More was better. That less was better, but more was better, right?
More was
Well, I don't mean to interrupt you, but I've had a similar evolution. I actually the first time I started doing endobrow lifts, I took a course with Oscar Ramirez around 1995 thereabouts, and I got back and I was very excited about it. I thought this was a big advance over the coronal approach, which, as you've experienced, as you make an incision from ear to ear, you transect the ascending sensory nerves, and they can have prolonged numbness. And also, I probably cranked up some brows too high in the beginning with a coronal brow lift. But we did that, I think, in anticipation that it was going to fall, that it was going to come down. At least that's my concept of it. But of course, some of them didn't fall, and their brows were too high. I never liked direct brow lifts, and I still don't. I know there are some advocates, even today, who believe that you can make an incision above the brow, close it, and see imperceptible brows. I think that only works in men who have big bushy eyebrows, where you can kind of camouflage it. But that's my bias anyway. I am extraordinarily impressed with this article that you and Dr. Viterbo from Brazil co-authored on the sliding brow lift, and I consider that very, very important. And first, let me ask you what is that procedure? How did it evolve? And how does that differ from a subcutaneous brow lift that's been around for a while? Or is that just another evolution of it?
Well, we'll start with number one. How did it evolve? Why did we start? Why did I
Yeah.
adopt it? Once again, we talked about the unpredictability of the endoscopic brow lift. And there were a lot of guys who were doing subcutaneous brow lifts, and they've been doing that literally for as long as they've been doing coronal brow lifts, because there were advocates 40 years ago using a subcutaneous plane with an anterior hairline incision that went all the way across the front. And though it was Fogli, who is a French plastic surgeon who really advocated for a limited incision subcutaneous dissection and was doing skin excision, but it took larger incisions, and it was relying on suspension of the skin up in the scalp. And so you would take a wedge of skin and get it lifted and try to take it up in that subcutaneous plane. So let me give you a background on the anatomy of the forehead. That'll be good for our readers or for your listeners who aren't plastic surgeons and even the plastic surgeons to understand the concept of what a gliding brow lift really is. So there are planes in the face that have been described by a gentleman called Brian Mendelsohn, and he described gliding planes, and he's been very unbelievably genius at describing ligamentous attachments, the different layers of the face and how they're stuck together. Well, when you look at the forehead, the muscle that raises our forehead stops at the temporal line. It's called the frontalis muscle, and that's what raises the forehead. Well, on the outside of that line, there is no muscle. There is a plane, a glide plane that's here, and that was described by a gentleman named David Nyes 20-some years ago. And so this glide plane moves up and down. As we age, the frontalis muscle, the attachments to the bone, they don't change a whole lot. However, this outside of the brow, where there's no muscular attachment, where the skin is loosely attached to a fascial plane, and then you have a glide plane between the deeper layers, it's the part that descends. So you have, number one, a plane that's not adhesive to any bone. It's on the outside, lateral to the ligamentous attachments, and you don't have any agonist muscles to the depressor. So the smile muscle, the orbicularis, is continually pulling the tail of the brow in a downward direction. So if you look at aging faces, most often it's the tail of the brow that falls.
Right.
So where the idea for the gliding brow lift really started with this concept of a surgical net. That was the first evolution. The surgical net was described by Andre and Louise Arsvald, and it was essentially a necessity. They call it necessity is the mother of invention. So just as a quick background of what a surgical net is, because you can't understand the gliding brow. The surgical net was first described in the Brazilian literature in 2012 by these two brothers, these crazy brothers from Curitiba, Brazil. They had a 14% hematoma rate with their facelifts. And it was jeopardizing Andre's relationship with his wife because she had to answer the phone every night and said, "Andre, you have another hematoma." And so at bedside, one night at bedside, they said, "Oh, I don't want to go back to the operating room and take care of this hematoma." So they suctioned the blood out, and based on the principles of Riccardo Berruti, they put some stitches through the skin to the deep layers tissues to essentially, like we used to do, or we do for full thickness skin grafts, to kill the dead space. So it couldn't bleed anymore. So let's close this dead space so it can't bleed. Well, that evolved from just a bedside hematoma management to using it during surgery to prevent hematomas. So they did enough of it to show that you can put these sutures through the face, weaving them through the face, through the skin, to the deep tissue, all over the face. It looks like that cartoon Hellraiser. And you could leave it on for 48 you could leave it
Yeah.
on for 48 to 72 hours and there's no scarring. And so, when I first saw it, I said, I'll never do that. That's crazy. Now the
I
fast,
my first reaction was my patients are never going to go for that. They look like crazy people, right? Because they
no,
have.
never going to try it. And so really was slow to adopt it for my facelifts, but I was visiting them in 2016, 2017. And so there's a gentleman named Fausto Viterbo. Fausto Viterbo is a plastic surgeon from Botucatu outside of the city of São Paulo in the state of São Paulo, Brazil. And he's a genius. He's the guy who invented the end-of-the-side nerve, and now everybody does it. And and it's so popular that a lot of the American plastic surgeons claim that they invented it after they laughed him off the stage 30 years ago. So,
Uh,
and that's the way original ideas
okay.
happen, right?
Yeah.
so, so
It's
Fausto came up with this idea that he could move tissue into a new place and put these sutures in that Andre Arsvald and Louise Arsvald invented, and it would hold it there. And you could do that with minimal incisions. Go ahead.
no. I'm listening. It's an interesting dialogue about and historical retelling of what happened. Because I think it's amazing how some people, I think in the United States, for just as a digression, in the United States, I think because the medical legal environment is different, it probably inhibits innovation to some degree. Because I don't know if many people would have the guts to create this crazy web on somebody's face, and I'm just saying it took guts to go forward with that in a sense, and I think I happened to hear Arsvold's lecture at a meeting on facelifting, and I saw it. And I said his results were incredible, and I was very impressed with it. And then I somehow I lost track of what was going on with the brow evolution in terms of the literature. But then I see that pops up as a addition to Viterbo's approach to the brow, which was to weave these sutures up on the forehead. And tell me, what is that actually doing? What are those sutures doing? Are they creating fixation, or are they inhibiting bleeding, or are they doing both?
So once again, we'll go back to this evolution so you can understand why we think that it works.
Okay, I'm sorry to cut you off.
Oh, no, that's okay. But you're exactly right. I think understanding the historical perspective and the timeline is critical for understanding how we got to where we are today. Because what we have evolved from are observations based on the fact that this surgical net didn't just achieve complete hemostasis while the net was on, but we found that it was speeding the recovery of our facelift patients. And we were able to take this really loose skin and in the lower neck and predictably stick it exactly where we wanted, and it would stay there. And it stayed there only with fixation for 48 to 72 hours. So, just to fast forward, and I'll go back to that point of fixation, but today I've published several papers. I'm doing lip lifts and jowl lifts through incisions in the corner of the nose that are 5 millimeters, and dissecting the entire face and doing fixation with sutures, holding the corners of the mouth up and the jowls up just with those little incisions based on these figures. My colleague Ozan Sozar is taking this brow lift, and he's doing complete facelifts with the surgical net through incisions that are this big in the scalp. So it comes back to your question is, why does it work? We know that it works from anecdotal evidence. I've done at least 1,000 brow lifts, because every facelift now gets a brow lift based on these concepts without any incisions. We think it works to your point, as you pointed out, is that we have multiple points of fixation. So if you put a suture on the brow, the sutures for this Hellraiser looking suturing threads through the facelift, there are going to be hundreds and hundreds of points where that needle goes through the skin and it catches the deep tissue and it eliminates the micro collections of fluids, because that micro collection of fluid prevents adhesions of the soft tissue. So that, and those adhesions will happen quickly. As an oculoplastic surgeon, at a transconjunctival incision, you go back, if you have to look at it at the end of the operation, it's already stuck together. I mean, you've got to pull it apart. So the body quickly adheses itself as long as there's not a layer of fluid between those layers. So number one, we're eliminating microfluid collections. Number two, each one of those needle points are going through the skin, and we surmise that it's creating an inflammatory response, like little spot welds. A metal worker uses multiple spot welds to hold two sheets of metal together. Well, we're using multiple little inflammatory points of fixation that create spot welding. And then the third point that we think is going on is the skin accommodation. Skin accommodation has been talked about by the dermatological surgeons forever, where they'll do a Mohs surgery, leave the hole open, and end up with a beautifully aesthetic result. From forehead flaps where you leave a big hole, it contracts. So the skin will accommodate.
Yeah.
So we think we have
right here.
right?
I had a hole right here. I let it heal by secondary intention, right?
And it leaves just as good.
Is that what you're saying?
Yeah, that's exactly what it does. It heals by secondary tension because of contraction. So those three factors, elimination of microfluid collection, multi-point inflammatory response, and the skin accommodation theories allow the skin to stay in the position that we put it. So the critical part of a gliding brow lift, the two innovative components that we published were, number one, we're doing it through a limited incision. So the incision literally is 3 millimeters in size. And we're following the concept of a subcutaneous separation of the skin from the deep structures, which include the frontalis muscle, the orbicularis muscle around the eyelid, and the temporal skin off the temporal parietal fascia. Because remember, for our listeners, the eyebrow itself is an adnexal structure. It's a skin structure. It's hair in the skin. So when we separate the skin and the hair from the underlying orbicularis, we can then not only, this concept of lift, yes, we can lift it, but we can reshape it. We can actually, if we have asymmetry, we can lift one side and pull the other side down. If we have brows,
and this is why I was particularly interested in this subject, because endoscopically I could never balance it out. Number one, because I'm in a much deeper plane. I could never get that contouring like you said. And the other thing is, of course, you don't recess the hairline, which is that correct?
Correct. No recession.
There's no recession of the hairline.
No.
Yeah. So you can take somebody with a high forehead, a man or a woman, and you don't push their hairline back any further, because you're making incisions relatively anterior to their hairline. Is that correct?
Correct. Exactly.
Okay. What happens when you move the skin up? Now there's a wave of you're undermining it. Now aren't you lifting that skin a little bit and creating a little fold up here?
Exactly. There will be a bunching of skin at the hairline. And that is where the skin accommodation, the skin shrinkage comes in, because that that bump goes away because the body adapts.
Yeah. Right. But I've seen that on a facelift as well. I've seen that happen on a facelift. So if you make an incision around here, around your ear, and there's a little kind of a bump here, over time it fades. So do you have to go up along the hairline? Is that a necessary incision?
So,
because I think that skin accommodation occurs on the face.
You are 100% correct, Joel. since I've adopted the gliding brow lift and the surgical net, my sideburn, my incision stops at the edge of the sideburn. And then through this incision, I'll do a subcutaneous temporal undermining. And so on all of my facelifts, this undermining will go all the way to the tail of the brow. So this bunching that you get here then gets redistributed to this area with the surgical net. And that skin, it avoids this vertical incision. You get the temporal brow up, and when
Yeah.
the face comes up, this bunching of skin that you can see from the facelift goes away without the vertical incision.
Right. Okay. Great. Yeah. So, okay. I kind of noticed that a long time ago, but I didn't realize it was related to that secondary contraction. Um, do you get any nerve motor injuries over here? I've heard stories of people doing this gliding, or is it now called sliding brow lift, um, and, and getting nerve injuries of the temporal area because they think that they pop through the wrong plane, or what is your experience with that?
So,
What kind of problems have you encountered with this procedure?
well, there's no question that I think number one, there can be nerve injuries if you're in the wrong plane. It doesn't matter whether you're doing a gliding brow lift, whatever you're doing. If you're in the wrong plane,
Correct.
you
Yeah.
you injure something. That's a risk of surgery, no question. And early
Right.
in your learning curve, you're going to have more problems than you do later in your learning curve, no matter what the procedure
Of
is.
course.
A gliding brow lift's no different. So if
Right. Okay.
no different. So the
Okay.
th- the thing that happens with motor function is that you're separating the skin from the underlying motor unit, which is the frontalis muscle. So you will
Right.
get temporary kinetic or movement problems, or not problems, but changes because the skin has to re-adhere to the underlying muscle to get that tight adhesive component of muscle and skin. The second thing that can happen if you're over aggressive in separation, you can get some sensory changes. So there can be numbness here too. And so you've got to
Hmm.
be, it's just like any surgery, you have to be gentle with it. Now, in
Hmm.
this area where where the frontal branch of the facial nerve runs, it runs deep in the temporal parietal fascia, but at the lateral edge of the muscle, it's going to become more superficial. And as you release
Oh.
this temporal ligament, which is
Hmm.
densely adherent from skin to the bone, that is an area where it's easy for your dissection to go deep or more superficial.
Oh. Okay.
So you've
Okay.
got to be very careful over this region. Now, I have colleagues in Belgium that have adopted this on all their cases. I know Patrick Tenard and Alex Veripale,
Yeah.
Ozan Sozar. These guys use it every day, and they've evolved to making the incision a little larger and using scissors under direct vision to separate it to make sure you're in the right plane.
Okay. Okay.
The
Okay. Okay.
instrumentation that we published were using dissectors that were round and blunt, and we would stick them into the
Right.
skin and separate it bluntly. So there's no question that your risk of going into the wrong layer at the temporal attachments is going to be greater doing a blind dissection with a blunt instrument than it will be under minimized direct vision.
Okay. So maybe that's a modification that we might have to adopt for those who aren't as experienced as you.
When I'm doing a facelift, I have no incisions on the forehead. I do everything through this
Oh.
lateral incision under direct vision. So I do a
Okay.
lighted
Yeah.
retractor from here, and through from my sideburn incision, I can see the temporal line, I can see the frontalis muscle,
Oh.
and then under direct vision using a micro tip cautery, I follow the orbicularis and the temporal parietal fascia to the temporal line, go through the temporal line, pick up the frontalis muscle under direct vision with my lighted retractor, and take that dissection as far medially as I need to. I
Oh,
know that Ozan Sozar has shown videos where he's gone through this temporal incision with a back cut up in the hairline, just a little back cut, and actually removed the corrugator musculature under direct vision from this lateral
wow.
dissection, looking at that. So you can do it under direct vision, and no forehead incisions, not even a tiny incision at the forehead. Now, I'll give you some pointers, Joe. One of the critical
Wait
aspects.
a minute now. I'm going to stop you right there.
Okay.
Can you do a guy, if you see a guy like me and we need a brow lift, you can do it through this temporal incision only?
Yes.
Oh,
Nope.
wow. That's
And actually,
amazing.
it's easier in a male because you can accommodate the skin as far back as you need to.
Wow. That's a real, so that's a even further development of this technique. That's another step beyond, actually.
Another step beyond. I have a paper that's getting ready to come out in the facial plastic surgery journal, Soletti's journal, and it talks about the evolution from hemostasis to gliding surgery. So we actually have evolved with an entire new field of gliding surgery, where we're gliding all parts of the face with minimal incisions.
And you said facelifts too, right?
Facelifts, closed facelifts, lip lifts. We're
Wow.
using it.
I saw your paper on lip lifts, which you commented in the PRS journal on. Yes, I read that. Yes, that was very interesting. So this is a very fascinating area. I'm very intrigued. Now, another question is: do you leave sutures in near the temporal brow a little longer? Because I noticed some people leave them in beyond the 2 or 3 days.
Well, the surgical net I leave it on for 72 hours. In fact, in men that are prone to bleed, I'll leave it on for 5 days, and I've not had a problem with scarring in well over 1,000 cases.
Oh,
But as far as the brow
oh
lift
wow.
itself, I will put a 5-O-proline, 2 of them, to shape the brow where I want it to reposition the adnexal tissue to the deep orbicularis musculature. And I will leave those for 6 to 7 days. Now,
Oh,
the reason I use a proline is because it's blue, and so when my nurses remove the surgical net, they leave the blue sutures and take out the black 5-O nylon.
I see. Okay, okay, that's good.
Now,
So you know,
let me give you one technical point, Joel, about the
yeah.
forehead lift that makes things easier going backwards about the separation of these planes. The critical thing is a good tumescent solution in the subcutaneous plane helps you do a hydrodissection to separate the skin from the underlying muscle. So I use a spatulated tip cannula that I will then use to pre-tunnel with my tumescent solution, and I will first put it in before I scrub. And then if I'm doing eyelid surgery, I do the eyelids first, and then I'll come back and put more tumescent solution right before I do the dissection. And I get it from Hayden. It's a tiny little spatulated cannula that then I'll pre-tunnel
Oh.
with my tumescent solution to create that easier plane for dissection.
Any other complications that you have had? Have you pulled the brow too high, for instance? Have you had any failures? Have any of the brows come down? Because Viterbo said he had a few. So I just wanted to ask you.
I have absolutely had brows fall back down. Early in my series,
Yeah.
it was a great operation, and I looked at it and said, well, this isn't much better than endoscopic brow. And so what we learned is early, we were stopping the dissection at the tail of the brow. So if I'm trying to get the tail of the brow up, I will take my dissection to the zygomatic arch. And I will frequently take my dissection down to the lower orbicularis, so the entire lateral orbicularis and skin comes up together. And so that has diminished my
Oh.
relapse rate. So, and we learned the
Oh.
same thing with lip lifting. If I'm trying to get the corner of the lip up, then I need to go down to the plane between the depressor labii inferioris and the DAO to release the commissure. If I'm trying to eliminate the marionette line, I need to go to the jowls. If I'm trying to lift the jowls, I do the dissection across the mandibular ligament. So you need to be releasing more distal to the point you're trying to lift. And that's the same thing we did with the endoscopic brow. we stopped the dissection here and it would relapse. So then we became more aggressive with the release down along the lateral orbital rim. A lot of people were releasing the sentinel vein. So the other complications you asked about, so relapse for sure. And as far as too high, I have not raised one too high. We have a tendency, to overcorrect, and people like Ozan his eyes will look like this and they come down. I've not had this problem, but Ozan has published some papers or cases where he had one brow that came down, the other one didn't. And so what he did was repeated the operation. And if you see it early, it's easy to do in your office. Otherwise, you let the glide plane set up and you re-release the leg. I have not had this, but I have seen two cases because I am a large referral source from around the world through my international connections for problems. So people send me problems and ask me opinions regularly. It's enough to scare me not to do it. I've seen at least two cases, let me back up now, three cases where people have killed the skin. So the skin can die for a couple of reasons. It can come from dissection too superficial, making it too superficial. The second reason could be putting the surgical net on too tight. And the third reason could be from putting it on in a random pattern. So, when we're putting this on, we're putting them in rows so that you get this elevation. Now, we just published a paper in the Aesthetic Surgery Journal this year, which we looked at patients where we did very large cervical facial flaps for melanoma reconstruction, injected the patients with indigo green before and after the application of the surgical net, and then took a camera, infrared camera, and then used something called spyware that measured the perfusion through the skin. And so we measured perfusion through the flaps before and after the application of the surgical net, and we found zero interruption of the blood supply. And in fact, in some of the cases, we found that the distal edges of the flap, because we were recruiting skin with the surgical net, actually the skin edges looked a little more robust. It wasn't statistically significant, but it proved that we weren't diminishing blood supply to the distal edges of the flap. We published one paper where we had one single brow where one side wasn't lifted, the other side was lifted in a paralysis patient, and you could see no difference in uptake of the indigo green in the lifted side and the non-lifted side. So we know that the surgical net, when properly applied, will not interrupt blood supply. But like any other surgical procedure, when it's not done properly, it can have complications. And so that's not to say, there's complications, don't do this operation. Well, don't drive because you could die today in a car wreck.
Right, exactly. You just brought up, I can go on and on forever. I could keep you here all day, but I got to ask you what, you just brought up a subject that is very, very important, and that is the patient who has a Bell's palsy and has a unilateral brow ptosis. One brow is down and the other one is okay. Can you unilaterally raise this with a gliding brow lift and create symmetry?
You absolutely can get it up as a static procedure. Now, because the facial paralysis patient still has movement of the other side, your optimal result is going to be to Botox this side, see where the brow ends up, completely wipe it out.
You mean on the good side?
On the good side.
Yeah.
See where your symmetry is, and then make a determination of what you're going to do. So you can actually, there was a paper Viterbo, Fausto just published, where you can do a nerve ablation on the good side, completely denervate the good side, and then do a static brow lift so the brows are symmetrical and symmetrically non-moving. That would be
But
the
what
optimal.
if you did it? Oh, that's the optimal. Okay. What happens? What happened? Okay. So, but you can raise it on one side, and it won't. Obviously, it's not going to move because there's no muscle movement. But the brow elevation will stick on the side that you elevate.
Yeah. In
Unilaterally.
in non-facial paralysis patients, I will use a unilateral brow lift frequently because we see asymmetrical brows all the time. And so during my facelifts, I will extend my dissection as just part of my facelift. Don't even call it a brow lift. I'm just creating symmetry.
Okay, well, listen, this, Dr. O'Daniel, this, I'm going to call you, I don't want to call you by your first name, Jerry,
Please.
but I want to say this has been a extremely enlightening encounter. I am so happy. I'm glad I persisted in trying to get you online here because I've had so many questions that have been unanswered. And I think that the audience, both professionals and non-professionals, will derive a lot of insight on where things are evolving in terms of brow lifting, you certainly have, you and your colleagues from Brazil have really advanced the field tremendously, and I thank you so much, and I mean that sincerely. I really am very, very excited about this. So thank you again, and I appreciate your time.